Section 11 of Gray's Anatomy, Part 2. Section 11. Humeral articulation, or shoulder joint. Articulatio humeri. The shoulder joint is an enarthrodial or ball-and-socket joint. The bones entering into its formation are the hemispherical head of the humerus and the shallow glenoid cavity of the scapula, an arrangement which permits a very considerable movement, while the joint itself is protected against displacement by the tendons which surround it. The ligaments do not maintain the joint surfaces in apposition, because when they alone remain, the humerus can be separated to a considerable extent from the glenoid cavity. Their use, therefore, is to limit the amount of movement. The joint is protected above by an arch, formed by the coracoid process, the acromion, and the coracoacromial ligament. The articular cartilage on the head of the humerus is thicker at the center than at the circumference, the reverse being the case with the articular cartilage of the glenoid cavity. The ligaments of the shoulder are the articular capsule, the coracohumeral, the glenohumeral, the transverse humeral, the glenoidal labrum. Footnote: the long tendon of origin of the biceps brachii also acts as one of the ligaments of this joint. See the observations on page 287 on the function of the muscles passing over more than one joint. End of footnote. The articular capsule, capsula articularis, capsular ligament. The articular capsule completely encircles the joint, being attached above to the circumference of the glenoid cavity beyond the glenoid labrum, below to the anatomical neck of the humerus, approaching nearer to the articular cartilage above than in the rest of its extent. It is thicker above and below than elsewhere, and is so remarkably loose and lax that it has no action in keeping the bones in contact, but allows them to be separated from each other more than 2.5 centimeters, an evident provision for that extreme freedom of movement which is peculiar to this articulation. It is strengthened above by the supraspinatus, below by the long head of the triceps brachii, behind by the tendons of the infraspinatus and teres minor, and in front by the tendon of the subscapularis. There are usually 3 openings in the capsule. One anteriorly, below the coracoid process, establishes a communication between the joint and a bursa beneath the tendon of the subscapularis. The second, which is not constant, is at the posterior part, where an opening sometimes exists between the joint and a bursal sac under the tendon of the infraspinatus. The third is between the tubercles of the humerus, for the passage of the long tendon of the biceps brachii. The coracohumeral ligament, ligamentum coracohumerale. This ligament is a broad band which strengthens the upper part of the capsule. It arises from the lateral border of the coracoid process and passes obliquely downward and lateralward to the front of the greater tubercle of the humerus, blending with the tendon of the supraspinatus. This ligament is intimately united to the capsule by its hinder and lower border, but its anterior and upper border presents a free edge which overlaps the capsule. Glenohumeral ligaments. In addition to the coracohumeral ligament, 3 supplemental bands, which are named the glenohumeral ligaments, strengthen the capsule. These may be best seen by opening the capsule at the back of the joint and removing the head of the humerus. One on the medial side of the joint passes from the medial edge of the glenoid cavity to the lower part of the lesser tubercle of the humerus. A second, at the lower part of the joint, extends from the under edge of the glenoid cavity to the under part of the anatomical neck of the humerus. A third, at the upper part of the joint, is fixed above to the apex of the glenoid cavity, close to the root of the coracoid process, and passing downward along the medial edge of the tendon of the biceps brachii, is attached below to a small depression above the lesser tubercle of the humerus. In addition to these, the capsule is strengthened in front by 2 bands derived from the tendons of the pectoralis major and the teres major, respectively. The transverse humeral ligament is a broad band passing from the lesser to the greater tubercle of the humerus, and always limited to that portion of the bone which lies above the epiphyseal line. It converts the intertubercular groove into a canal, and is the homologue of the strong process of bone which connects the summits of the 2 tubercles in the musk ox. The glenoidal labrum, Labrium glenoidale, glenoid ligament, is a fibrocartilaginous rim attached around the margin of the glenoid cavity. It is triangular on section, the base being fixed to the circumference of the cavity, while the free edge is thin and sharp. It is continuous above with the tendon of the long head of the biceps brachii, which gives off two fasciculi to blend with the fibrous tissue of the labrum. It deepens the articular cavity and protects the edges of the bone. Synovial membrane. The synovial membrane is reflected from the margin of the glenoid cavity over the labrum. It is then reflected over the inner surface of the capsule and covers the lower part and sides of the anatomical neck of the humerus as far as the articular cartilage on the head of the bone. The tendon of the long head of the biceps brachii passes through the capsule and is enclosed in a tubular sheath of synovial membrane, which is reflected upon it from the summit of the glenoid cavity and is continued around the tendon into the intertubercular groove, as far as the surgical neck of the humerus. The tendon thus traverses the articulation, but is not contained within the synovial cavity. Bursae. The bursae in the neighborhood of the shoulder joint are the following. 1. A constant bursa is situated between the tendon of the subscapularis muscle and the capsule. It communicates with the synovial cavity through an opening in the front of the capsule. 2. A bursa which occasionally communicates with the joint is sometimes found between the tendon of the infraspinatus and the capsule. 3. A large bursa exists between the undersurface of the deltoideus and the capsule, but does not communicate with the joint. This bursa is prolonged under the acromion and the coracoacromial ligament and intervenes between these structures and the capsule. 4. A large bursa is situated on the summit of the acromion. 5. A bursa is frequently found between the coracoid process and the capsule. 6. A bursa exists beneath the coracobrachialis. 7. One lies between the teres major and the long head of the triceps brachii. 8. One is placed in front of, and another behind, the tendon of the latissimus dorsi. The muscles in relation with the joint are above the supraspinatus, below the long head of the triceps brachii, in front the subscapularis, behind the infraspinatus and teres minor, within the tendon of the long head of the biceps brachii. The deltoideus covers the articulation in front, behind, and laterally. The arteries supplying the joint are articular branches of the anterior and posterior humeral circumflex and transverse scapular. The nerves are derived from the axillary and suprascapular. Movements. The shoulder joint is capable of every variety of movement: flexion, extension, abduction, adduction, circumduction, and rotation. The humerus is flexed, drawn forward, by the pectoralis major, anterior fibers of the deltoideus, coracobrachialis, and when the forearm is flexed, by the biceps brachii. Extended, drawn backward, by the latissimus dorsi, teres major, posterior fibers of the deltoideus, and, when the forearm is extended, by the triceps brachii. It is abducted by the deltoideus and supraspinatus. It is adducted by the subscapularis, pectoralis major, latissimus dorsi, and teres major, and by the weight of the limb. It is rotated outward by the infraspinatus and teres minor, and it is rotated inward by the subscapularis, latissimus dorsi, teres major, pectoralis major, and the anterior fibers of the deltoideus. The most striking peculiarities in this joint are: 1. The large size of the head of the humerus in comparison with the depth of the glenoid cavity, even when this latter is supplemented by the glenoid labrum. 2. The looseness of the capsule of the joint. 3. The intimate connection of the capsule with the muscles attached to the head of the humerus. 4. The peculiar relation of the tendon of the long head of the biceps brachii to the joint. It is in consequence of the relative sizes of the two articular surfaces and the looseness of the articular capsule that the joint enjoys such free movement in all directions. When these movements of the arm are arrested in the shoulder joint by the contact of the bony surfaces and by the tension of the fibers of the capsule, together with that of the muscles acting as accessory ligaments, the arm can be carried considerably farther by the movements of the scapula, involving, of course, motion of the acromio and sternoclavicular joints. These joints are therefore to be regarded as accessory structures to the shoulder joint. The extent of the scapular movements is very considerable, especially in extreme elevation of the arm, a movement best accomplished when the arm is thrown somewhat forward and outward, because the margin of the head of the humerus is by no means a true circle. Its greatest diameter is from the intertubercular groove, downward, medialward, and backward, and the greatest elevation of the arm can be obtained by rolling its articular surface in the direction of this measurement. The great width of the central portion of the humeral head also allows a very free horizontal movement when the arm is raised to a right angle, in which movement the arch formed by the acromion, the coracoid process, and the coracoacromial ligament constitutes a sort of supplemental articular cavity for the head of the bone. The looseness of the capsule is so great that the arm will fall about 2.5 centimeters from the scapula when the muscles are dissected from the capsule, and an opening made in it to counteract the atmospheric pressure. The movements of the joint, therefore, are not regulated by the capsule so much as by the surrounding muscles and by the pressure of the atmosphere, an arrangement which renders the movements of the joint much more easy than they would otherwise have been, and permits a swinging, pendulum-like vibration of the limb when the muscles are at rest. Humphrey. The fact also that in all ordinary positions of the joint the capsule is not put on the stretch enables the arm to move freely in all directions. Extreme movements are checked by the tension of appropriate portions of the capsule, as well as by the interlocking of the bones. Thus it is said that abduction is checked by the contact of the great tuberosity with the upper edge of the glenoid cavity, by the tension of the coracohumeral ligament. Bonny et Bouchard. Cleland maintains that the limitations of movement at the shoulder joint are due to the structure of the joint itself, the glenoidal labrum fitting in different positions of the elevated arm into the anatomical neck of the humerus. The scapula is capable of being moved upward and downward, forward and backward, or by a combination of these movements circumducted on the wall of the chest. The muscles which raise the scapula are the upper fibers of the trapezius, the levator scapulae, and the rhomboidii. Those which depress it are the lower fibers of the trapezius, the pectoralis minor, and through the clavicle, the subclavius. The scapula is drawn backward by the rhomboidii and the middle and lower fibers of the trapezius, and forward by the serratus anterior and pectoralis minor, assisted, when the arm is fixed, by the pectoralis major. The mobility of the scapula is very considerable, and greatly assists the movements of the arm at the shoulder joint. Thus, in raising the arm from the side, the deltoideus and supraspinatus can only lift it to a right angle with the trunk, the further elevation of the limb being effected by the trapezius and the serratus anterior moving the scapula on the wall of the chest. This mobility is of special importance in ankylosis of the shoulder joint, the movements of this bone compensating to a very great extent for the immobility of the joint. Cathcart has pointed out that in abducting the arm and raising it above the head, the scapula rotates through the whole movement, with the exception of a short space at the beginning and at the end, that the humerus moves on the scapula not only while passing from the hanging to the horizontal position, but also in traveling upward as it approaches the vertical above, that the clavicle moves not only during the second half of the movement, but in the first as well, though to a less extent. That is, the scapula and clavicle are concerned in the first stage as well as in the second, and that the humerus is partly involved in the second as well as chiefly in the first. The intimate union of the tendons of the supraspinatus, infraspinatus, teres minor, and subscapularis with the capsule converts these muscles into elastic and spontaneously acting ligaments of the joint. The peculiar relations of the tendon of the long head of the biceps brachii to the shoulder joint appear to subserve various purposes. In the first place, by its connection with both the shoulder and elbow, the muscle harmonizes the action of the two joints, and acts as an elastic ligament in all positions, in the manner previously discussed. It strengthens the upper part of the articular cavity, and prevents the head of the humerus from being pressed up against the acromion. When the deltoideus contracts, it thus fixes the head of the humerus as the center of motion in the glenoid cavity. By its passage along the intertubercular groove, it assists in steadying the head of the humerus in the various movements of the arm. When the arm is raised from the side, it assists the supraspinatus and infraspinatus in rotating the head of the humerus in the glenoid cavity. It also holds the head of the bone firmly in contact with the glenoid cavity, and prevents its slipping over its lower edge, or being displaced by the action of the latissimus dorsi and pectoralis major, as in climbing and many other movements. End of Section 11. Section 12 of Gray's Anatomy, Part 2. Elbow joint. Articulatio cubiti. The elbow joint is a ginglymus or hinge joint. The trochlea of the humerus is received into the semi-lunar notch of the ulna, and the capitulum of the humerus articulates with the fovea on the head of the radius. The articular surfaces are connected together by a capsule, which is thickened medially and laterally, and, to a less extent, in front and behind. These thickened portions are usually described as distinct ligaments under the following names: the anterior, the posterior, the ulnar collateral, the radiocollateral. The anterior ligament. The anterior ligament is a broad and thin fibrous layer covering the anterior surface of the joint. It is attached to the front of the medial epicondyle and to the front of the humerus immediately above the coronoid and radial fossae below, to the anterior surface of the coronoid process of the ulna, and to the annular ligament, being continuous on either side with the collateral ligaments. Its superficial fibers pass obliquely from the medial epicondyle of the humerus to the annular ligament. The middle fibers, vertical in direction, pass from the upper part of the coronoid depression and become partly blended with the preceding, but are inserted mainly into the anterior surface of the coronoid process. The deep or transverse set intersects these at right angles. This ligament is in relation, in front, with the brachialis, except at its most lateral part. The posterior ligament. This posterior ligament is thin and membranous, and consists of transverse and oblique fibers. Above, it is attached to the humerus immediately behind the capitulum and close to the medial margin of the trochlea, to the margins of the olecranon fossa, and to the back of the lateral epicondyle, some little distance from the trochlea. Below, it is fixed to the upper and lateral margins of the olecranon, to the posterior part of the annular ligament, and to the ulna behind the radial notch. The transverse fibers form a strong band which bridges across the olecranon fossa. Under cover of this band, a pouch of synovial membrane and a pad of fat project into the upper part of the fossa when the joint is extended. In the fat are a few scattered fibrous bundles, which pass from the deep surface of the transverse band to the upper part of the fossa. This ligament is in relation, behind, with the tendon of the triceps brachii and the anconeus. The ulnar collateral ligament. Ligamentum collaterale ulnare. Internal lateral ligament. This ligament is a thick triangular band consisting of two portions, an anterior and posterior, united by a thinner intermediate portion. The anterior portion, directed obliquely forward, is attached above by its apex to the front part of the medial epicondyle of the humerus, and below by its broad base to the medial margin of the coronoid process. The posterior portion, also of triangular form, is attached above by its apex to the lower and back part of the medial epicondyle, below to the medial margin of the olecranon. Between these two bands, a few intermediate fibers descend from the medial epicondyle to blend with a transverse band which bridges across the notch between the olecranon and the coronoid process. This ligament is in relation with the triceps brachii and flexor carpi ulnaris and the ulnar nerve, and gives origin to part of the flexor digitorum sublimis. The radial collateral ligament. Ligamentum collaterale radiali. External lateral ligament. This ligament is a short and narrow fibrous band, less distinct than the ulnar collateral, attached above to a depression below the lateral epicondyle of the humerus, below to the annular ligament, some of its most posterior fibers passing over that ligament to be inserted into the lateral margin of the ulna. It is intimately blended with the tendon of origin of the supinator. Synovial membrane. The synovial membrane is very extensive. It extends from the margin of the articular surface of the humerus and lines the coronoid, radial, and olecranal fossae on that bone. It is reflected over the deep surface of the capsule and forms a pouch between the radial notch, the deep surface of the annular ligament, and the circumference of the head of the radius. Projecting between the radius and ulna into the cavity is a crescentic fold of synovial membrane, suggesting the division of the joint into two, one of the humeroradial, the other the humeral ulnar. Between the capsule and the synovial membrane are three masses of fat. The largest, over the olecranon fossa, is pressed into the fossa by the triceps brachii during the flexion, the second, over the coronoid fossa, and the third, over the radial fossa, are pressed by the brachialis into their respective fossae during extension. The muscles in relation with the joint are, in front, the brachialis, behind the triceps brachii and anconeus, laterally the supinator and the common tendon of origin of the extensor muscles, medially the common tendon of origin of the flexor muscles and the flexor carpi ulnaris. The arteries supplying the joint are derived from the anastomosis between the profunda and superior and inferior ulnar collateral branches of the brachial, with the anterior, posterior, and interosseosus recurrent branches of the ulnar and the recurrent branch of the radial. These vessels form a complete anastomotic network around the joint. The nerves of the joint are a twig from the ulnar as it passes between the medial condyle and olecranon, a filament from the musculocutaneous, and two from the median. Movements. The elbow joint comprises three different portions, namely, the joint between the ulna and humerus, that between the head of the radius and the humerus, and the proximal radioulnar articulation described below. All these articular surfaces are enveloped by a common synovial membrane, and the movements of the whole joint should be studied together. The combination of the movements of flexion and extension of the forearm with those of pronation and supination of the hand, which is ensured by the two being performed at the same joint, is essential to the accuracy of the various minute movements of the hand. The portion of the joint between the ulna and the humerus is a simple hinge joint and allows of movements of flexion and extension only. Owing to the obliquity of the trochlea of the humerus, this movement does not take place in the antero-posterior plane of the body of the humerus. When the forearm is extended and supinated, the axes of the arm and forearm are not in the same line. The arm forms an obtuse angle with the forearm, the hand and forearm being directed lateralward. During flexion, however, the forearm and the hand tend to approach the middle line of the body, and thus enable the hand to be easily carried to the face. The accurate adaptation of the trochlea of the humerus, with its prominences and depressions, to the semi-lunar notch of the ulna prevents any lateral movement. Flexion is produced by the action of the biceps brachii and brachialis, assisted by the brachioradialis and the muscles arising from the medial condyle of the humerus. Extension by the triceps brachii and anconeus, assisted by the extensors of the wrist, the extensor digitorum communis, and the extensor digiti quinti proprius. The joint between the head of the radius and the capitulum of the humerus is an arthrodial joint. The bony surfaces would of themselves constitute an inarthrosis and allow of movement in all directions, were it not for the annular ligament, by which the head of the radius is bound to the radial notch of the ulna, and which prevents any separation of the two bones laterally. It is to the same ligament that the head of the radius owes its security from dislocation, which would otherwise tend to occur, from the shallowness of the cup-like surface on the head of the radius. In fact, but for this ligament, the tendon of the biceps brachii would be liable to pull the head of the radius out of the joint. The head of the radius is not in complete contact with the capitulum of the humerus in all positions of the joint. The capitulum occupies only the anterior and inferior surfaces of the lower end of the humerus, so that in complete extension a part of the radial head can be plainly felt projecting at the back of the articulation. In full flexion, the movement of the radial head is hampered by the compression of the surrounding soft parts, so that the freest rotary movement of the radius on the humerus, pronation and supination, takes place in semiflexion, in which position the two articular surfaces are in most intimate contact. Flexion and extension of the elbow joint are limited by the tension of the structures on the front and back of the joint. The limitation of flexion is also aided by the soft structures of the arm and forearm coming into contact. In any position of flexion or extension, the radius, carrying the hand with it, can be rotated in the proximal radioulnar joint. The hand is directly articulated to the lower surface of the radius only, and the ulnar notch on the lower end of the radius travels around the lower end of the ulna. The latter bone is excluded from the wrist joint by the articular disc. Thus, rotation of the head of the radius around an axis passing through the center of the radial head of the humerus imparts circular motion to the hand through a very considerable arc. End of section 12.
Section 13 of the Gray's Anatomy, Part 2. Radioulnar Articulation. Articulatio radioulnaris. The articulation of the radius with the ulna is affected by ligaments which connect together the extremities as well as the bodies of these bones. The ligaments may consequently be subdivided into three sets. 1. Those of the proximal radioulnar articulation. 2. The middle radioulnar ligaments. 3. Those of the distal radioulnar articulation. Proximal radioulnar articulation. Articulatio radioulnaris proximalis. Superior radioulnar joint. This articulation is a trochoid or pivot joint between the circumference of the head of the radius and the ring formed by the radial notch of the ulna and the annular ligament. The annular ligament. Ligamentum annulare radi. Orbicular ligament. This ligament is a strong band of fibers which encircles the head of the radius and retains it in contact with the radial notch of the ulna. It forms about 4/5 of the osteofibrous ring and is attached to the anterior and posterior margins of the radial notch. A few of its lower fibers are continued around below the cavity and form at this level a complete fibrous ring. Its upper border blends with the anterior and posterior ligaments of the elbow, while from its lower border a thin loose membrane passes to be attached to the neck of the radius, a thickened band which extends from the inferior border of the annular ligament below the radial notch to the neck of the radius is known as the quadrate ligament. The superficial surface of the annular ligament is strengthened by the radial collateral ligament of the elbow and affords origin to part of the supinator. Its deep surface is smooth and lined by a synovial membrane which is continuous with that of the elbow joint. Movements. The movements allowed in this articulation are limited to rotatory movements of the head of the radius within the ring formed by the annular ligament and the radial notch of the ulna. Rotation forward being called pronation, rotation backward supination. Supination is performed by the biceps brachii and supinator, assisted to a slight extent by the extensor muscles of the thumb. Pronation is performed by the pronator teres and pronator quadratus. Middle radioulnar union. The shafts of the radius and ulna are connected by the oblique cord and the interosseous membrane. The oblique cord, chorda obliqua, oblique ligament. The oblique cord is a small flattened band extending downward and lateralward from the lateral surface of the tubercle of the ulna at the base of the coronoid process to the radius a little below the radial tuberosity. Its fibers run in the opposite direction to those of the interosseous membrane. It is sometimes wanting. The interosseous membrane, membrana interossea antebrachii. The interosseous membrane is a broad and thin plane of fibrous tissue descending obliquely downward and medialward from the interosseous crest of the radius to that of the ulna. The lower part of the membrane is attached to the posterior of the two lines into which the interosseous crest of the radius divides. It is deficient above, commencing about 2.5 centimeters beneath the tuberosity of the radius, is broader in the middle than at either end, and presents an oval aperture a little above its lower margin for the passage of the volar interosseous vessels to the back of the forearm. This membrane serves to connect the bones and to increase the extent of surface for the attachment of the deep muscles. Between its upper border and the oblique cord is a gap through which the dorsal interosseous vessels pass. 2 or 3 fibrous bands are occasionally found on the dorsal surface of this membrane. They descend obliquely from the ulna towards the radius and have consequently a direction contrary to that of the other fibers. The membrane is in relation in front by its upper 3/4 with the flexor pollicis longus on the radial side and with the flexor digitorum profundus on the ulnar, lying in the interval between which are the volar interosseous vessels and nerve, by its lower fourth with the pronator quadratus, behind with the supinator, abductor pollicis longus, extensor pollicis brevis, extensor pollicis longus, extensor indicis proprius, and near the wrist with the volar interosseous artery and dorsal interosseous nerve. Distal radioulnar articulation. Articulatio radioulnaris distalis. Inferior radioulnar joint. This is a pivot joint formed between the head of the ulna and the ulnar notch on the lower end of the radius. The articular surfaces are connected together by the following ligaments: the volar radioulnar, the dorsal radioulnar, the articular disc. The volar radioulnar ligament, anterior radioulnar ligament. This ligament is a narrow band of fibers extending from the anterior margin of the ulnar notch of the radius to the front of the head of the ulna. The dorsal radioulnar ligament, posterior radioulnar ligament. This ligament extends between corresponding surfaces on the dorsal aspect of the articulation. The articular disc, discus articularis, triangular fibrocartilage. The articular disc is triangular in shape and is placed transversely beneath the head of the ulna, binding the lower ends of the ulna and radius firmly together. Its periphery is thicker than its center, which is occasionally perforated. It is attached by its apex to a depression between the styloid process and the head of the ulna, and by its base, which is thin, to the prominent edge of the radius, which separates the ulnar notch from the carpal articular surface. Its margins are united to the ligaments of the wrist joint. Its upper surface, smooth and concave, articulates with the head of the ulna, forming an arthroidal joint. Its undersurface, also concave and smooth, forms part of the wrist joint and articulates with the triangular bone and medial part of the lunate. Both surfaces are clothed by synovial membrane, the upper by that of the distal radioulnar articulation, the under by that of the wrist. Synovial membrane. The synovial membrane of this articulation is extremely loose and extends upward as a recess sacciformis, between the radius and the ulna. Movements. The movements in the distal radioulnar articulation consist of rotation of the lower end of the radius around an axis which passes through the center of the head of the ulna. When the radius rotates forward, pronation of the forearm and hand is the result, and when backward, supination. It will thus be seen that in pronation and supination, the radius describes the segment of a cone, the axis of which extends from the center of the head of the radius to the middle of the head of the ulna. In this movement, the head of the ulna is not stationary but describes a curve in a direction opposite to that taken by the head of the radius. This, however, is not to be regarded as a rotation of the ulna. The curve which the head of this bone describes is due to a combined antero-posterior and rotatory movement, the former taking place almost entirely at the elbow joint, the latter at the shoulder joint. Radiocarpal articulation or wrist joint. Articulatio radiocarpi. The wrist joint is a condyloid articulation. The parts forming it are the lower end of the radius and undersurface of the articular disc above, and the navicular, lunate, and triangular bones below. The articular surface of the radius and the undersurface of the articular disc form together a transversely elliptical concave surface, the receiving cavity. The superior articular surfaces of the navicular, lunate, and triangular form a smooth convex surface, the condyle, which is received into the concavity. The joint is surrounded by a capsule strengthened by the following ligaments: the volar radiocarpal, the dorsal radiocarpal, the ulnar collateral, the radial collateral. The volar radiocarpal ligament. Ligamentum radiocarpium volare, anterior ligament. This ligament is a broad membranous band attached above to the anterior margin of the lower end of the radius, to its styloid process, and to the front of the lower end of the ulna. Its fibers pass downward and medialward to be inserted into the volar surfaces of the navicular, lunate, and triangular bones, some being continued to the capitate. In addition to this broad membrane, there is a rounded fasciculus, superficial to the rest, which reaches from the base of the styloid process of the ulna to the lunate and triangular bones. The ligament is perforated by apertures for the passage of vessels, and is in relation in front with the tendons of the flexor digitorum profundus and flexor pollicis longus. Behind, it is closely adherent to the anterior border of the articular disc of the distal radioulnar articulation. The dorsal radiocarpal ligament. Ligamentum radiocarpium dorsale, posterior ligament. The dorsal radiocarpal ligament, less thick and strong than the volar, is attached above to the posterior border of the lower end of the radius. Its fibers are directed obliquely downward and medialward and are fixed. Below to the dorsal surfaces of the navicular, lunate, and triangular, being continuous with those of the dorsal intercarpal ligaments. It is in relation behind with the extensor tendons of the fingers. In front, it is blended with the articular disc. The ulnar collateral ligament, ligamentum collaterale carpi ulnar. Internal lateral ligament. The ulnar collateral ligament is a rounded cord attached above to the end of the styloid process of the ulna and dividing below into two fasciculi, one of which is attached to the medial side of the triangular bone, the other to the pisiform and transverse carpal ligament. The radial collateral ligament, ligamentum collaterale carpi radiale. External lateral ligament. The radial collateral ligament extends from the tip of the styloid process of the radius to the radial side of the navicular, some of its fibers being prolonged to the greater multangular bone and the transverse carpal ligament. It is in relation with the radial artery, which separates the ligament from the tendons of the abductor pollicis longus and extensor pollicis brevis. Synovial membrane. The synovial membrane lines the deep surfaces of the ligaments above described, extending from the margin of the lower end of the radius and articular disc above to the margins of the articular surfaces of the carpal bones below. It is loose and lax and presents numerous folds, especially behind. The wrist joint is covered in front by the flexor and behind by the extensor tendons. The arteries supplying the joint are the volar and dorsal carpal branches of the radial and ulnar, the volar and dorsal metacarpals, and some ascending branches from the deep volar arch. The nerves are derived from the ulnar and dorsal interosseous. Movements. The movements permitted in this joint are flexion, extension, abduction, adduction, and circumduction. They will be studied with those of the carpus with which they are combined. End of section 13.
Section 14 of Gray's Anatomy, Part 2. Intercarpal articulations. Articulations intercarpae. Articulations of the carpus. These articulations may be subdivided into three sets. Number 1. The articulations of the proximal row of carpal bones. Number 2. The articulations of the distal row of carpal bones. Number 3. The articulations of the two rows with each other. Articulations of the proximal row of carpal bones. These are arthroidal joints. The navicular, lunate, and triangular are connected by dorsal, volar, and interosseous ligaments. The dorsal ligaments, ligamenta intercarpae dorsalia. The dorsal ligaments, 2 in number, are placed transversely behind the bones of the first row. They connect the navicular and lunate, and the lunate and triangular. The volar ligaments, ligamenta intercarpi volaria. Palmar ligaments. The volar ligaments also too connect the navicular and lunate and the lunate and triangular. They are less strong than the dorsal and placed very deeply behind the flexor tendons and the volar radiocarpal ligament. The interosseous ligaments, ligamenta intercarpi interossea. The interosseous ligaments are two narrow bundles, one connecting the lunate with the navicular, the other joining it to the triangular. They are on a level with the superior surfaces of these bones, and their upper surfaces are smooth and form part of the convex articular surface of the wrist joint. The ligaments connecting the pisiform bone are the articular capsule and the two volar ligaments. The articular capsule is a thin membrane which connects the pisiform to the triangular. It is lined by synovial membrane. The two volar ligaments are strong fibrous bands. One, the pisohamate ligament, connects the pisiform to the hamate. The other, the pisometacarpal ligament, joins the pisiform to the base of the fifth metacarpal bone. These ligaments are, in reality, prolongations of the tendon of the flexor carpi ulnaris. Articulations of the distal row of carpal bones. These also are arthroidal joints. The bones are connected by dorsal, volar, and interosseous ligaments. The dorsal ligaments, ligamenta intercarpi dorsalia. The dorsal ligaments, 3 in number, extend transversely from one bone to other on the dorsal surface, connecting the greater with the lesser multangular with the capitate, and the capitate with the hamate. The volar ligaments, ligamenta intercarpi volaria, palmar ligaments. The volar ligaments, also 3, have a similar arrangement on the volar surface. The interosseous ligaments, ligamenta intercarpi interossea. The 3 interosseous ligaments are much thicker than those of the first row. One is placed between the capitate and the hamate, a second between the capitate and the lesser multangular, and a third between the greater and lesser multangulars. The first is much the strongest, and the third is sometimes wanting. Articulations of the 2 rows of carpal bones with each other. The joint between the navicular, lunate, and triangular on the one hand and the second row of carpal bones on the other is named the midcarpal joint and is made up of 3 distinct portions. In the center, the head of the capitate and the superior surface of the hamate articulate with the deep cup-shaped cavity formed by the navicular and lunate and constitute a sort of ball and socket joint. On the radial side, the greater and lesser multangulars articulate with the navicular, and on the ulnar side, the hamate articulates with the triangular, forming gliding joints. The ligaments are volar, dorsal, ulnar, and radial collateral. The volar ligaments, ligamenta intercarpi volaria. Anterior or palmar ligaments. The volar ligaments consist of short fibers which pass, for the most part, from the volar surfaces of the bones of the first row to the front of the capitate. The dorsal ligaments, ligamenta intercarpae dorsalia, posterior ligaments. The dorsal ligaments consist of short, irregular bundles passing between the dorsal surfaces of the bones of the first and second rows. The collateral ligaments, lateral ligaments. The collateral ligaments are very short. One is placed on the radial, the other on the ulnar side of the carpus. The former, the stronger and more distinct, connects the navicular and greater multangular. The later, the triangular and hamate, they are continuous with the collateral ligaments of the wrist joint. In addition to these ligaments, a slender interosseous band sometimes connects the capitate and the navicular. Synovial membrane. The synovial membrane of the carpus is very extensive and bounds a synovial cavity of very irregular shape. The upper portion of the cavity intervenes between the undersurfaces of the navicular, lunate and triangular bones and the upper surfaces of the bones of the second row. It sends two prolongations upward between the navicular and lunate and the lunate and triangular, and three prolongations downward between the four bones of the second row. The prolongation between the greater and lesser multangulars, or that between the lesser multangular and capitate, is, owing to the absence of the interosseous ligament, often continuous with the cavity of the carpometacarpal joints, sometimes of the second, third, fourth and fifth metacarpal bones, sometimes of the second and third only. In the later condition, the joint between the hamate and the fourth and fifth metacarpal bones has a separate synovial membrane. The synovial cavities of these joints are prolonged for a short distance between the bases of the metacarpal bones. There is a separate synovial membrane between the pisiform and triangular. Movements. The articulation of the hand and wrist considered as a whole involves four articular surfaces. A. The inferior surfaces of the radius and the articular disc. B. The superior surfaces of the navicular, lunate and triangular, the pisiform having no essential part in the movement of the hand. C. The S-shaped surface formed by the interior surfaces of the navicular, lunate and triangular. D. The reciprocal surface formed by the upper surfaces of the bones of the second row. These four surfaces form two joints. 1. A proximal, the wrist joint proper, and 2. A distal, the mid-carpal joint. 1. The wrist joint proper is a true condyloid articulation, and therefore all movements but rotation are permitted. Flexion and extension are the most free, and of these a greater amount of extension than of flexion is permitted, since the articulating surfaces extend farther on the dorsal than on the volar surfaces of the carpal bones. In this movement, the carpal bones rotate on a transverse axis drawn between the tips of the styloid processes of the radius and ulna. A certain amount of adduction or ulnar flexion and abduction or radial flexion is also permitted. The former is considerably greater in extent than the latter on account of the shortness of the styloid process of the ulna, abduction being soon limited by the contact of the styloid process of the radius with the greater multangular. In this movement, the carpus revolves upon an antero-posterior axis drawn through the center of the wrist. Footnote: H. M. Johnston, Journal of Anatomy and Physiology, Volume 41, maintains that ulnar and radial flexion, only slight lateral movement occurs at the radiocarpal joint, and that in complete flexion and extension of the hand there is a small degree of ulnar flexion at the radiocarpal joint. End footnote. Finally, circumduction is permitted by the combined and consecutive movements of adduction, extension, abduction, and flexion. No rotation is possible, but the effect of rotation is obtained by the pronation and supination of the radius on the ulna. The movement of flexion is performed by the flexor carpi radialis, the flexor carpi ulnaris, and the palmaris longus. Extension by the extensors carpi radialis longus and brevis, and the extensor carpi ulnaris. Adduction, ulnar flexion by the flexor carpi ulnaris and the extensor carpi ulnaris. Abduction, radial flexion by the abductor pollicis longus, the extensors of the thumb, and the extensors carpi radialis longus and brevis, and the flexor carpi radialis. When the fingers are extended, flexion of the wrist is performed by the flexor carpi radialis and ulnaris, and extension is aided by the extensor digitorum communis. When the fingers are flexed, flexion of the wrist is aided by the flexors digitorum sublimis and profundus, and extension is performed by the extensors carpi radialis and ulnaris. Number 2. The chief movements permitted in the mid-carpal joint are flexion and extension and a slight amount of rotation. In the flexion and extension, which are the movements most freely enjoyed, the greater and lesser multangulars on the radial side and the hamate on the ulnar side glide forward and backward on the navicular and triangular respectively, while the head of the capitate and the superior surface of the hamate rotate in the cup-shaped cavity of the navicular and lunate. Flexion at this joint is freer than extension. A very trifling amount of rotation is also permitted, the head of the capitate rotating around a vertical axis drawn through its own center, while at the same time a slight gliding movement takes place in the lateral and medial portions of the joint. End of section 14.
Section 15 of Gray's Anatomy, Part 2. Carpometacarpal articulations. Articulations, Carpometacarpal. Carpometacarpal articulation of the thumb. Articulatio Carpometacarpi pollicis. This is a joint of reciprocal reception between the first metacarpal and the greater multangular. It enjoys great freedom of movement on account of the configuration of its articular surfaces, which are saddle-shaped. The joint is surrounded by a capsule which is thick but loose and passes from the circumference of the base of the metacarpal bone to the rough edge bounding the articular surface of the greater multangular. It is thickest laterally and dorsally and is lined by synovial membrane. Movements. In this articulation, the movements permitted are flexion and extension in the plane of the palm of the hand,
adduction and abduction in a plane at right angles to the palm, circumduction and apposition. It is by the movement of apposition that the tip of the thumb is brought into contact with the volar surfaces of the slightly flexed fingers. This movement is effected through the medium of a small sloping facet on the anterior lip of the saddle-shaped articular surface of the greater multangular. The flexure muscles pull the corresponding part of the articular surface of the metacarpal bone onto this facet, and the movement of apposition is then carried out by the adductors. Flexion of this joint is produced by the flexors pollicis longus and brevis, assisted by opponens pollicis and adductor pollicis. Extension is effected mainly by the abductor pollicis longus, assisted by extensors pollicis longus and brevis. Adduction is carried out by the adductor, abduction mainly by the abductors pollicis longus and brevis, assisted by the extensors. Articulations of the other four metacarpal bones with the carpus. Articulations Carpometacarpal. The joints between the carpus and the second, third, fourth, and fifth metacarpal bones are arthroidal. The bones are united by dorsal, volar, and interosseous ligaments. The dorsal ligaments, ligamenta Carpometacarpae dorsalia. The dorsal ligaments, the strongest and most distinct, connect the carpal and metacarpal bones on their dorsal surfaces. The second metacarpal bone receives two fasciculi, one from the greater, the other from the lesser multangular. The third metacarpal receives two, one each from the lesser multangular and capitate. The fourth, two, one each from the capitate and the hamate. The fifth receives a single fasciculus from the hamate, and this is continuous with a similar ligament on the volar surface, forming an incomplete capsule. The volar ligaments, ligamenta Carpometacarpae volaria, palmar ligaments. The volar ligaments have a somewhat similar arrangement, with the exception of those of the third metacarpal, which are three in number, a lateral one from the greater multangular, situated superficial to the sheath of the tendon of the flexure carpi radialis, an intermediate one from the capitate, and a medial one from the hamate. Interosseous ligaments. The interosseous ligaments consist of short, thick fibers and are limited to one part of the carpometacarpal articulation. They connect the contiguous inferior angles of the capitate and hamate with the adjacent surfaces of the third and fourth metacarpal bones. Synovial membrane. The synovial membrane is a continuation of that of the intercarpal joints. Occasionally, the joint between the hamate and the fourth and fifth metacarpal bones has a separate synovial membrane. The synovial membranes of the wrist and carpus are thus seen to be 5 in number. The first passes from the lower end of the ulnar to ulnar notch of the radius and lines the upper surface of the articular disc. The second passes from the articular disc and the lower end of the radius above to the bones of the first row below. The third, the most extensive, passes between the contiguous margins of the two rows of carpal bones and sometimes in the event of one of the interosseous ligaments being absent between the bones of the second row to the carpal extremities of the second, third, fourth, and fifth metacarpal bones. The fourth extends from the margin of the greater multangular to the metacarpal bone of the thumb. The fifth runs between the adjacent margins of the triangular and pisiform bones. Occasionally, the fourth and fifth metacarpal joints have a separate synovial membrane. Movements. The movements permitted in the carpometacarpal articulations of the fingers are limited to slight gliding of the articular surfaces upon each other, the extent of which varies in different joints. The metacarpal bone of the little finger is most movable than that of the ring finger. The metacarpal bones of the index and middle fingers are almost immovable. Intermetacarpal articulations. Articulations intercarpi, articulations of the metacarpal bones with each other. The bases of the second, third, fourth, and fifth metacarpal bones articulate with one another by small surfaces covered with cartilage and are connected together by dorsal, volar, and interosseous ligaments. The dorsal ligamenta basium osseous metacarp dorsalia and volar ligaments, ligamenta basium osseous metacarp volaria, palmar ligaments, pass transversely from one bone to another on the dorsal and volar surfaces. The interosseous ligaments, ligamenta basium osteometacarp interossea, connect their contiguous surfaces just distal to their collateral articular facets. The synovial membrane for these joints is continuous with that of the carpometacarpal articulations. The transverse metacarpal ligament, ligamentum capitularium, osteometacarpalium, transversum. This ligament is a narrow fibrous band which runs across the volar surfaces of the heads of the second, third, fourth, and fifth metacarpal bones, connecting them together. It is blended with the volar glenoid ligaments of the metacarpophalangeal articulations. Its volar surface is concave, where the flexor tendons pass over it. Behind it, the tendons of the interossi pass to their insertions. Metacarpophalangeal articulations. Articulations metacarpophalangeal. Metacarpophalangeal joints. These articulations are of condyloid kind, formed by the reception of the rounded heads of the metacarpal bones into shallow cavities on the proximal ends of the first phalanges, with the exception of that of thumb, which presents more of the characters of a ginglamoid joint. Each joint has a volar and two collateral ligaments. The volar ligaments, glenoid ligaments of Humeral, palmar, or vaginal ligaments. The volar ligaments are thick, dense, fibrocartilaginous structures placed upon the volar surfaces of the joints in the intervals between the collateral ligaments to which they are connected. They are loosely united to the metacarpal bones but are very firmly attached to the bases of the first phalanges. Their volar surfaces are intimately blended with the transverse metacarpal ligament and present grooves for the passage of the flexor tendons, the sheaths surrounding which are connected to the sides of the grooves. Their deep surfaces form parts of the articular facets for the heads of the metacarpal bones and are lined by synovial membranes. The collateral ligaments, ligamenta collateralia, lateral ligaments. The collateral ligaments are strong, rounded cords placed on the sides of the joints. Each is attached by one extremity to the posterior tubercle and adjacent depression on the side of the head of the metacarpal bone, and by the other to the contiguous extremity of the phalanx. The dorsal surface of these joints are covered by the expansions of the extensor tendons together with some loose areolar tissue which connects the deep surfaces of the tendons to the bones. Movements. The movements which occur in these joints are flexion, extension, adduction, abduction, and circumduction. The movements of abduction and adduction are very limited and cannot be performed when the fingers are flexed. Articulations of the digits. Articulations digitorum manus. Interphalangeal joints. The interphalangeal articulations are hinge joints. Each has a volar and two collateral ligaments. The arrangement of these ligaments is similar to those in the metacarpophalangeal articulations. The extensor tendons supply the place of posterior ligaments. Movements. The only movements permitted in the interphalangeal joints are flexion and extension. These movements are more extensive between the first and second phalanges than between the second and third. The amount of flexion is very considerable, but extension is limited by the volar and collateral ligaments. Muscles acting on the joints of the digits. Flexion of the metacarpophalangeal joints of the fingers is effected by the flexors digitorum, sublimis and profundus, lubricales and interossi, assisted in the case of the little finger by the flexor digiti quinti brevis. Extension is produced by the extensor digitorum communis, extensor indicis proprius, and extensor digiti quinti proprius. Flexion of the interphalangeal joints of the fingers is accomplished by the flexor digitorum profundus acting on the proximal and distal joints, and by the flexor digitorum sublimis acting on the proximal joints. Extension is mainly effected by the lubricales and interossi, the long extensors having little or no action upon these joints. Flexion of the metacarpophalangeal joint of the thumb is effected by the flexors pollicis longus and brevis. Extension by the extensors pollicis longus and brevis. Flexion of the interphalangeal joint is accomplished by the flexor pollicis longus and extension by the extensor pollicis longus. End of section 15.
Section 16 of Gray's Anatomy, Part 2. 7. Articulations of the lower extremity. A. Coxal articulation or hip joint. The articulations of the lower extremity comprise the following: 1. Hip, 2. Knee, 3. Tibiofibula, 4. Ankle, 5. Intertarsal, 6. Tarsometatarsal, 7. Intermetatarsal, 8. Metacarpophalangeal, 9. Articulations of the digits. Coxal articulation or hip joint. Articulatio coxae. This articulation is an enarthrodial or ball and socket joint, formed by the reception of the head of the femur into the cup-shaped cavity of the acetabulum. The articular cartilage on the head of the femur, thicker at the centre than at the circumference, covers the entire surface with the exception of the fovea capitis femoris, to which the ligamentum teres is attached. That on the acetabulum forms an incomplete marginal ring, the lunate surface. Within the lunate surface there is a circular depression devoid of cartilage, occupied in the fresh state by a mass of fat, covered by synovial membrane. The ligaments of the joint are the articular capsule, the iliofemoral, the ischiocapsular, the pubocapsular, the ligamentum teres femoris, the glenoidal labrum, the transverse acetabula. The articular capsule, capsula articularis, capsular ligament. The articular capsule is strong and dense. Above, it is attached to the margin of the acetabulum, 5 to 6 millimetres beyond the glenoidal labrum behind. But in front, it is attached to the outer margin of the labrum, and opposite to the notch where the margin of the cavity is deficient, it is connected to the transverse ligament, and by a few fibres to the edge of the obturator foramen. It surrounds the neck of the femur, and is attached in front to the intertrochanteric line, above to the base of the neck, behind to the neck about 1.25 centimetres above the intertrochanteric crest, below to the lower part of the neck, close to the lesser trochanter. From its femoral attachment, some of the fibres are reflected upward along the neck as longitudinal bands, termed retinacular. The capsule is much thicker at the upper and fore part of the joint, where the greatest amount of resistance is required. Behind and below, it is thin and loose. It consists of 2 sets of fibres, circular and longitudinal. The circular fibres, zona orbicularis, are most abundant at the lower and back part of the capsule, and form a sling or collar around the neck of the femur. Anteriorly, they blend with the deep surface of the iliofemoral ligament, and gain an attachment to the anterior inferior iliac spine. The longitudinal fibres are greatest in amount at the upper and front part of the capsule, where they are reinforced by distinct bands or accessory ligaments, of which the most important is the iliofemoral ligament. The other accessory bands are known as the pubocapsular and the ischiocapsular ligaments. The external surface of the capsule is rough, covered by numerous muscles, and separated in front from the psoas major and iliacus by a bursa, which not infrequently communicates by a circular aperture with the cavity of the joint. The iliofemoral ligament, ligamentum iliofemorale, Y ligament, ligament of Bigelow. The iliofemoral ligament is a band of great strength which lies in front of the joint. It is intimately connected with the capsule and serves to strengthen it in this situation. It is attached above to the lower part of the anterior inferior iliac spine. Below it divides into two bands, one of which passes downward and is fixed to the lower part of the intertrochanteric line. The other is directed downward and lateralward and is attached to the upper part of the same line. Between the two bands is a thinner part of the capsule. In some cases there is no division, and the ligament spreads out into a flat triangular band which is attached to the whole length of the intertrochanteric line. This ligament is frequently called the Y-shaped ligament of Bigelow, and its upper band is sometimes named the iliotrochanteric ligament. The pubocapsular ligament, ligamentum pubocapsulare, pubofemoral ligament. This ligament is attached above to the obturator crest and the superior ramus of the pubis. Below, it blends with the capsule and with the deep surface of the vertical band of the iliofemoral ligament. The ischiocapsular ligament, ligamentum ischiocapsulare, ischiocapsular band, ligament of Bertin. The ischiocapsular ligament consists of a triangular band of strong fibres, which spring from the ischium below and behind the acetabulum, and blend with the circular fibres of the capsule. The ligamentum teres femoris. The ligamentum teres femoris is a triangular, somewhat flattened band implanted by its apex into the antero-superior part of the fovea capitis femoris. Its base is attached by two bands, one into either side of the acetabular notch, and between these bony attachments it blends with the transverse ligament. It is ensheathed by the synovial membrane and varies greatly in strength in different subjects. Occasionally only the synovial fold exists, and in rare cases even this is absent. The ligament is made tense when the thigh is semi-flexed, and the limb then adducted or rotated outward. It is, on the other hand, relaxed when the limb is abducted. It has, however, but little influence as a ligament. The glenoidal labrum, labrum glenoidale, cotyloid ligament. The glenoidal labrum is a fibrocartilaginous rim attached to the margin of the acetabulum, the cavity of which it deepens. At the same time it protects the edge of the bone and fills up the inequalities of its surface. It bridges over the notch as the transverse ligament, and thus forms a complete circle, which closely surrounds the head of the femur and assists in holding it in its place. It is triangular on section, its base being attached to the margin of the acetabulum, while its opposite edge is free and sharp. Its two surfaces are invested by synovial membrane, the external one being in contact with the capsule, the internal one being inclined inward so as to narrow the acetabulum and embrace the cartilaginous surface of the head of the femur. It is much thicker above and behind than below and in front, and consists of compact fibres. The transverse acetabular ligament, ligamentum transversum acetabulae, transverse ligament. This ligament is in reality a portion of the glenoidal labrum, though differing from it in having no cartilage cells among its fibres. It consists of strong flattened fibres which cross the acetabular notch and convert it into a foramen through which the nutrient vessels enter the joint. Synovial membrane. The synovial membrane is very extensive. Commencing at the margin of the cartilaginous surface of the head of the femur, It covers the portion of the neck which is contained within the joint. From the neck it is reflected on the internal surface of the capsule, covers both surfaces of the glenoidal labrum and the mass of fat contained in the depression at the bottom of the acetabulum, and ensheathes the ligamentum teres as far as the head of the femur. The joint cavity sometimes communicates through a hole in the capsule between the vertical band of the iliofemoral ligament and the pubocapsular ligament with a bursa situated on the deep surfaces of the psoas major and iliacus. The muscles in relation with the joint are, in front, the psoas major and iliacus, separated from the capsule by a bursa; above, the reflected head of the rectus femoris and gluteus minimus, the latter being closely adherent to the capsule; medially, the obturator externus and pectineus; behind, the piriformis, gemellus superior, obturator internus, gemellus inferior, obturator externus, and quadratus femoris. The arteries supplying the joint are derived from the obturator, medial femoral circumflex, and superior and inferior gluteals. The nerves are articular branches from the sacral plexus, sciatic, obturator, accessory obturator, and a filament from the branch of the femoral supplying the rectus femoris. Movements. The movements of the hip are very extensive and consist of flexion, extension, adduction, abduction, circumduction, and rotation. The length of the neck of the femur and its inclinations to the body of the bone have the effect of converting the angular movements of flexion, extension, adduction, and abduction partially into rotatory movements in the joint. Thus, when the thigh is flexed or extended, the head of the femur, on account of the medial inclination of the neck, rotates within the acetabulum with only a slight amount of gliding to and fro. The forward slope of the neck similarly affects the movements of adduction and abduction. Conversely, rotation of the thigh, which is permitted by the upward inclination of the neck, is not a simple rotation of the head of the femur in the acetabulum, but is accompanied by a certain amount of gliding. The hip joint presents a very striking contrast to the shoulder joint in the much more complete mechanical arrangements for its security and for the limitation of its movements. In the shoulder, as has been seen, the head of the humerus is not adapted at all in size to the glenoid cavity, and is hardly restrained in any of its ordinary movements by the capsule. In the hip joint, on the contrary, the head of the femur is closely fitted to the acetabulum for an area extending over nearly half a sphere, and at the margin of the bony cup it is still more closely embraced by the glenoidal labrum, so that the head of the femur is held in its place by that ligament, even when the fibres of the capsule have been quite divided. The iliofemoral ligament is the strongest of all the ligaments in the body, and is put on the stretch by any attempt to extend the femur beyond a straight line with the trunk. That is to say, this ligament is the chief agent in maintaining the erect position without muscular fatigue. For a vertical line passing through the centre of gravity of the trunk falls behind the centres of rotation in the hip joints, and therefore the pelvis tends to fall backward, but is prevented by the tension of the iliofemoral ligaments. The security of the joint may be provided for also by the two bones being directly united through the ligamentum teres, but it is doubtful whether this ligament has much influence upon the mechanism of the joint. When the knee is flexed, flexion of the hip joint is arrested by the soft parts of the thigh and abdomen being brought into contact, and when the knee is extended, by the action of the hamstring muscles. Extension is checked by the tension of the iliofemoral ligament, adduction by the thighs coming into contact, adduction with flexion by the lateral band of the iliofemoral ligament and the lateral part of the capsule, abduction by the medial band of the iliofemoral ligament and the pubocapsular ligament, rotation outward by the lateral band of the iliofemoral ligament, and rotation inward by the ischiocapsular ligament and the hinder part of the capsule. The muscles which flex the femur on the pelvis are the psoas major, iliacus, rectus femoris, sartorius, pectineus, adductores longus and brevis, and the anterior fibres of the glutei medius and minimus. Extension is mainly performed by the gluteus maximus, assisted by the hamstring muscles and the ischial head of the adductor magnus. The thigh is adducted by the adductores magnus, longus, and brevis, the pectineus, the gracilis, and lower part of the gluteus maximus, and abducted by the glutei medius and minimus and the upper part of the gluteus maximus. The muscles which rotate the thigh inward are the gluteus minimus and the anterior fibres of the gluteus medius, the tensor fasciae latae, and the iliacus and psoas major, while those which rotate it outward are the posterior fibres of the gluteus medius, the piriformis, obturatores externus and internus, gemelli superior and inferior, quadratus femoris, gluteus maximus, the adductores longus, brevis, and magnus, the pectineus, and the sartorius. End of section 16.
Section 17 of Gray's Anatomy, Part 2. The knee joint. Articulatio genu. The knee joint was formerly described as the ginglymus or hinge joint, but is really of a much more complicated character. It must be regarded as consisting of three articulations in one: two condyloid joints, one between each condyle of the femur and the corresponding meniscus and the condyle of the tibia, and a third between the patella and the femur, part arthrodial, but not completely so, since the articular surfaces are not mutually adapted to each other, so that the movement is not a simple gliding one. This view of the construction of the knee joint receives confirmation from the study of the articulation in some of the lower mammals, where, corresponding to these three subdivisions, three synovial cavities are sometimes found, either entirely distinct or only connected together by small communications. This view is further rendered probable by the existence in the middle of the joint of the two cruciate ligaments, which must be regarded as the collateral ligaments of the medial and lateral joints. The existence of the patellar fold of synovial membrane would further indicate a tendency to separation of the synovial cavity into two minor sacs, one corresponding to the lateral and the other to the medial joint. The bones are connected together by the following ligaments: the articular capsule, the ligamentum patellae, the oblique popliteal, the tibial collateral, the fibula collateral, the anterior cruciate, the posterior cruciate, the medial and lateral menisci, the transverse, and the coronary. The articular capsule, capsular articularis, capsular ligament. The articular capsule consists of a thin but strong fibrous membrane, which is strengthened in almost its entire extent by bands inseparably connected with it. Above and in front, beneath the tendon of the quadriceps femoris, it is represented only by the synovial membrane. Its chief strengthening bands are derived from the fascia lata and from the tendons surrounding the joint. In front, expansions from the vasti and from the fascia lata and its iliotibial band fill in the intervals between the anterior and collateral ligaments, constituting the medial and lateral patellar retinacula. Behind the capsule consists of vertical fibres which arise from the condyles and from the sides of the intercondyloid fossa of the femur. The posterior part of the capsule is therefore situated on the sides of and in front of the cruciate ligaments, which are thus excluded from the joint cavity. Behind the cruciate ligaments is the oblique popliteal ligament, which is augmented by fibres derived from the tendon of the semimembranosus. Laterally, a prolongation from the iliotibial band fills in the interval between the oblique popliteal and the fibular collateral ligaments and partly covers the latter. Medially, expansions from the sartorius and the semimembranosus pass upward to the tibial collateral ligament and strengthen the capsule. The ligamentum patellae, anterior ligament. The ligamentum patellae is the central portion of the common tendon of the quadriceps femoris, which is continued from the patella to the tuberosity of the tibia. It is a strong, flat ligamentous band, about 8 centimetres in length, attached above to the apex and adjoining margins of the patella and the rough depression on its posterior surface. Below, to the tuberosity of the tibia, its superficial fibres are continuous over the front of the patella with those of the tendon of the quadriceps femoris. The medial and lateral portions of the tendon of the quadriceps pass down on either side of the patella to be inserted into the upper extremity of the tibia on either side of the tuberosity. These portions merge into the capsule, as stated above, forming the medial and lateral patella retinacula. The posterior surface of the ligamentum patellae is separated from the synovial membrane of the joint by a large infrapatellar pad of fat, and from the tibia by a bursa. The oblique popliteal ligament, ligamentum popliteum obliquum, posterior ligament. This ligament is a broad, flat, fibrous band formed of fasciculi separated from one another by apertures from the passage of vessels and nerves. It is attached above to the upper margin of the intercondyloid fossa and posterior surface of the femur, close to the articular margins of the condyles, and below to the posterior margin of the head of the tibia. Superficial to the main part of the ligament is a strong fasciculus, derived from the tendon of the semimembranosus and passing from the back part of the medial condyle of the tibia obliquely upward and lateralward to the back part of the lateral condyle of the femur. The oblique popliteal ligament forms part of the floor of the popliteal fossa, and the popliteal artery rests upon it. The tibial collateral ligament, ligamentum collateral tibial, internal lateral ligament. The tibial collateral is a broad, flat membranous band, situated nearer to the back than to the front of the joint. It is attached above to the medial condyle of the femur immediately below the adductor tubercle, below to the medial condyle and medial surface of the body of the tibia. The fibres of the posterior part of the ligament are short and incline backward as they descend. They are inserted into the tibia above the groove for the semimembranosus. The anterior part of the ligament is a flattened band, about 10 centimetres long, which inclines forward as it descends. It is inserted into the medial surface of the body of the tibia about 2.5 centimetres below the level of the condyle. It is crossed at its lower part by the tendons of the sartorius, gracilis, and semitendinosus, a bursa being interposed. Its deep surface covers the inferior medial genicular vessels and nerve, and the anterior portion of the tendon of the semimembranosus, with which it is connected by a few fibres. It is intimately adherent to the medial meniscus. The fibular collateral ligament, ligamentum collateral fibular, external lateral or long external lateral ligament. The fibular collateral is a strong, rounded, fibrous cord attached above to the back part of the lateral condyle of the femur, immediately above the groove for the tendon of the popliteus, below to the lateral side of the head of the fibula in front of the styloid process. The greater part of its lateral surface is covered by the tendon of the biceps femoris. The tendon, however, divides at its insertion into two parts, which are separated by the ligament. Deep to the ligament are the tendon of the popliteus and the inferior lateral genicular vessels and nerve. The ligament has no attachment to the lateral meniscus. An inconstant bundle of fibres, the short fibular collateral ligament, is placed behind and parallel with the preceding, attached above to the lower and back part of the lateral condyle of the femur, below to the summit of the styloid process of the fibula. Passing deep to it are the tendon of the popliteus and the inferior lateral genicular vessels and nerve. The cruciate ligaments, ligamenta, cruciata genu, crucial ligaments. The cruciate ligaments are of considerable strength, situated in the middle of the joint, nearer to its posterior than to its anterior surface. They are called cruciate because they cross each other somewhat like the lines of the letter X, and have received the names anterior and posterior from the position of their attachments to the tibia. The anterior cruciate ligament, ligamentum cruciatum anterius, external crucial ligament, is attached to the depression in front of the intercondyloid eminence of the tibia, being blended with the anterior extremity of the lateral meniscus. It passes upward, backward, and lateralward, and is fixed into the medial and back part of the lateral condyle of the femur. The posterior cruciate ligament, ligamentum cruciatum posterius, internal crucial ligament, is stronger but shorter and less oblique in its direction than the anterior. It is attached to the posterior intercondyloid fossa of the tibia and to the posterior extremity of the lateral meniscus, and passes upward, forward, and medialward to be fixed into the lateral and front part of the medial condyle of the femur. The menisci, semilunar fibrocartilages. The menisci are two crescentic lamellae, which serve to deepen the surfaces of the head of the tibia for articulation with the condyles of the femur. The peripheral border of each meniscus is thick, convex, and attached to the inside of the capsule of the joint. The opposite border is thin, concave, and free. The upper surfaces of the menisci are concave and in contact with the condyles of the femur. Their lower surfaces are flat and rest upon the head of the tibia. Both surfaces are smooth and invested by synovial membrane. Each meniscus covers approximately the peripheral 2/3 of the corresponding articular surface of the tibia. The medial meniscus, meniscus medialis, internal semilunar fibrocartilage, is nearly semicircular in form, a little elongated from before backward and broader behind than in front. Its anterior end, thin and pointed, is attached to the anterior intercondyloid fossa of the tibia, in front of the anterior cruciate ligament. Its posterior end is fixed to the posterior intercondyloid fossa of the tibia, between the attachments of the lateral meniscus and the posterior cruciate ligament. The lateral meniscus, meniscus lateralis, external semilunar fibrocartilage, is nearly circular and covers a larger portion of the articular surface than the medial one. It is grooved laterally for the tendon of the popliteus, which separates it from the fibular collateral ligament. Its anterior end is attached in front of the intercondyloid eminence of the tibia, lateral to and behind the anterior cruciate ligament with which it blends. The posterior end is attached behind the intercondyloid eminence of the tibia and in front of the posterior end of the medial meniscus. The anterior attachment of the lateral meniscus is twisted on itself so that its free margin looks backward and upward, its anterior end resting on a sloping shelf of bone on the front of the lateral process of the intercondyloid eminence. Close to its posterior attachment, it sends off a strong fasciculus, the ligament of Risberg, which passes upward and medialward to be inserted into the medial condyle of the femur, immediately behind the attachment of the posterior cruciate ligament. Occasionally a small fasciculus passes forward to be inserted into the lateral part of the anterior cruciate ligament. The lateral meniscus gives off from its anterior convex margin a fasciculus which forms the transverse ligament. The transverse ligament, ligamentum transversum genu. The transverse ligament connects the anterior convex margin of the lateral meniscus to the anterior end of the medial meniscus. Its thickness varies considerably in different subjects, and it is sometimes absent. The coronary ligaments are merely portions of the capsule, which connect the periphery of each meniscus with the margin of the head of the tibia. End of section 17, the knee joint. Recording by the Bodster. From The Human Body, Part 2, by Henry Gray. Section 18 of Gray's Anatomy, Part 2. The knee joint. Articulatio genu. Synovial membrane. The synovial membrane of the knee joint is the largest and most extensive in the body. Commencing at the upper border of the patella, it forms a large cul-de-sac beneath the quadriceps femoris, on the lower part of the front of the femur, and frequently communicates with a bursa interposed between the tendon and the front of the femur. The pouch of synovial membrane between the quadriceps and front of the femur is supported during the movement of the knee by a small muscle, the articularis genu, which is inserted into it. On either side of the patella, the synovial membrane extends beneath the aponeuroses of the vasti, and more especially beneath that of the vastus medialis. Below the patella, it is separated from the ligamentum patellae by a considerable quantity of fat, known as the infrapatellar pad. From the medial and lateral borders of the articular surface of the patella, reduplications of the synovial membrane project into the interior of the joint. These form two fringe-like folds termed the alar folds. Below, these folds converge and are continued as a single band, the patellar fold, ligamentum mucosum, to the front of the intercondyloid fossa of the femur. On either side of the joint, the synovial membrane passes downward from the femur, lining the capsule to its point of attachment to the menisci. It may then be traced over the upper surfaces of these to their free borders, and thence along their undersurfaces to the tibia. At the back part of the lateral meniscus, it forms a cul-de-sac between the groove on its surface and the tendon of the popliteus. It is reflected across the front of the cruciate ligaments, which are therefore situated outside the synovial cavity. Bursae. The bursae near the knee joint are the following. In front, there are 4 bursae. A large one is interposed between the patella and the skin, a small one between the upper part of the tibia and the ligamentum patellae, a third between the lower part of the tuberosity of the tibia and the skin, and a fourth between the anterior surface of the lower part of the femur and the deep surface of the quadriceps femoris, usually communicating with the knee joint. Laterally, there are 4 bursae, one which sometimes communicates with the joint, between the lateral head of the gastrocnemius and the capsule, one between the fibular-collateral ligament and the tendon of the biceps, one between the fibular-collateral ligament and the tendon of the popliteus. This is sometimes only an expansion from the next bursa, and one between the tendon of the popliteus and the lateral condyle of the femur, usually an extension from the synovial membrane of the joint. Medially, there are 5 bursae, one between the medial head of the gastrocnemius and the capsule. This sends a prolongation between the tendon of the medial head of the gastrocnemius and the tendon of the semimembranosus, and often communicates with the joint. One superficial to the tibial collateral ligament between it and the tendons of the sartorius, gracilis, and semitendinosus. One deep to the tibial collateral ligament between it and the tendon of the semimembranosus. This is sometimes only an expansion from the next bursa. one between the tendon of the semimembranosus and the head of the tibia, and occasionally there is a bursa between the tendons of the semimembranosus and the semitendinosus. Structures around the joint. In front and at the sides is the quadriceps femoris. Laterally, the tendons of the biceps femoris and popliteus and the common perineal nerve. Medially, the sartorius, gracilis, semitendinosus, and semimembranosus. Behind, the popliteal vessels and the tibial nerve, popliteus, plantaris, and medial and lateral heads of the gastrocnemius, some lymph glands, and fat. The arteries supplying the joints are the highest genicular, anastomotica magna, a branch of the femoral, the genicular branches of the popliteal, the recurrent branches of the anterior tibial, and the descending branch from the lateral femoral circumflex of the profunda femoris. The nerves are derived from the obturata, femoral, tibial, and common perineal. Movements. The movements which take place at the knee joint are flexion and extension, and, in certain positions of the joint, internal and external rotation. The movements of flexion and extension at this joint differ from those in a typical hinge joint, such as the elbow, in that a. the axis around which motion takes place is not a fixed one, but shifts forward during extension and backward during flexion, and b. the commencement of flexion and the end of extension are accompanied by rotatory movements associated with the fixation of the limb in a position of great stability. The movement from full flexion to full extension may therefore be described in 3 phases. 1. In the fully flexed condition, the posterior parts of the femoral condyles rest on the corresponding portions of the meniscotibial surfaces, and in this position a slight amount of simple rolling movement is allowed. 2. During the passage of the limb from the flexed to the extended position, a gliding movement is superposed on the rolling, so that the axis, which at the commencement is represented by a line through the inner and outer condyles of the femur, gradually shifts forward. In this part of the movement, the posterior 2/3 of the tibial articular surfaces of the 2 femoral condyles are involved, and as these have similar curvatures and are parallel to one another, they move forward equally. And 3. The lateral condyle of the femur is brought almost to rest by the tightening of the anterior cruciate ligament. It moves, however, slightly forward and medialward, pushing before it the anterior part of the lateral meniscus. The tibial surface on the medial condyle is prolonged farther forward than that on the lateral, and this prolongation is directed lateralward. When, therefore, the movement forward of the condyles is checked by the anterior cruciate ligament, continued muscular action causes the medial condyle, dragging with it the meniscus, to travel backward and medialward, thus producing an internal rotation of the thigh on the leg. When the position of full extension is reached, the lateral part of the groove on the lateral condyle is pressed against the anterior part of the corresponding meniscus, while the medial part of the groove rests on the articular margin in front of the lateral process of the tibial intercondyloid eminence. Into the groove on the medial condyle is fitted the anterior part of the medial meniscus, while the anterior cruciate ligament and the articular margin in front of the medial process of the tibial intercondyloid eminence are received into the forepart of the intercondyloid fossa of the femur. This third phase, by which all these parts are brought into accurate apposition, is known as the screwing home, or locking movement of the joint. The complete movement of flexion is the converse of that described above, and is therefore preceded by an external rotation of the femur, which unlocks the extended joint. The axes around which the movements of flexion and extension take place are not precisely at right angles to either bone. In flexion, the femur and tibia are in the same plane, but in extension, the one bone forms an angle, opening lateralward to the other. In addition to the rotary movements associated with the completion of extension and initiation of flexion, rotation inward or outward can be effected when the joint is partially flexed. These movements take place mainly between the tibia and the menisci, and are freest when the leg is bent at right angles with the thigh. Movements of patella. The articular surface of the patella is indistinctly divided into 7 facets: upper, middle, and lower horizontal pairs, and a medial perpendicular facet. When the knee is forcibly flexed, the medial perpendicular facet is in contact with the semilunar surface of the lateral part of the medial condyle. This semilunar surface is a prolongation backward of the medial part of the patellar surface. As the leg is carried from the flexed to the extended position, first the highest pair, then the middle pair, and lastly the lowest pair of horizontal facets, is successively brought into contact with the patellar surface of the femur. In the extended position, when the quadriceps femoris is relaxed, the patella lies loosely on the front of the lower end of the femur. During flexion, the ligamentum patellae is put upon the stretch, and in extreme flexion the posterior cruciate ligament, the oblique popliteal, and collateral ligaments, and to a slight extent the anterior cruciate ligament, are relaxed. Flexion is checked during life by the contact of the leg with the thigh. When the knee joint is fully extended, the oblique popliteal and collateral ligaments, the anterior cruciate ligament, and the posterior cruciate ligament are rendered tense. In the act of extending the knee, the ligamentum patellae is tightened by the quadriceps femoris, but in full extension, with the heel supported, it is relaxed. Rotation inward is checked by the anterior cruciate ligament. Rotation outward tends to uncross and relax the cruciate ligaments, but is checked by the tibial collateral ligament. The main function of the cruciate ligament is to act as a direct bond between the tibia and femur, and to prevent the former bone from being carried too far backward or forward. They also assist the collateral ligaments in resisting any bending of the joint to either side. The menisci are intended, as it seems, to adapt the surfaces of the tibia to the shape of the femoral condyles to a certain extent, so as to fill up the intervals which would otherwise be left in the varying positions of the joint, and to obviate the jars which would be so frequently transmitted up the limb in jumping or by falls on the feet. Also, to permit of the 2 varieties of motion, flexion and extension, and rotation, as explained above. The patella is a great defence to the front of the knee joint, and distributes upon a large and tolerably even surface, during kneeling, the pressure which would otherwise fall upon the prominent ridges of the condyles. It also affords leverage to the quadriceps femoris. When standing erect in the attitude of attention, the weight of the body falls in front of a line carried across the centres of the knee joints, and therefore tends to produce overextension of the articulations. This, however, is prevented by the tension of the anterior cruciate, oblique popliteal, and collateral ligaments. Extension of the leg on the thigh is performed by the quadriceps femoris, flexion by the biceps femoris, semitendinosus, and semimembranosus, assisted by the gracilis, sartorius, gastrocnemius, popliteus, and plantaris. Rotation outward is effected by the biceps femoris, and rotation inward by the popliteus, semitendinosus, and to a slight extent the semimembranosus, the sartorius, and the gracilis. The popliteus comes into action especially at the commencement of the movement of flexion of the knee. By its contraction, the leg is rotated inward, or, if the tibia be fixed, the thigh is rotated outward, and the knee joint is unlocked. End of section 18, the knee joint. Recorded by the Bodster. From Anatomy of the Human Body, Part 2, by Henry Gray.
Section 19 of Gray's Anatomy, Part 2. 7c. Articulations between the tibia and fibula. The articulations between the tibia and fibula are effected by ligaments which connect the extremities and bodies of the bones. The ligaments may consequently be subdivided into three sets: 1. Those of the tibio-fibular articulation; 2. The interosseous membrane; 3. Those of the tibio-fibular syndesmosis. Tibio-fibular articulation. Articulatio tibiofibularis, superior tibio-fibular articulation. This articulation is an arthrodial joint between the lateral condyle of the tibia and the head of the fibula. The contiguous surfaces of the bones present flat oval facets covered with cartilage, and connected together by an articular capsule and by anterior and posterior ligaments. The articular capsule. Capsula articularis, capsular ligament. The articular capsule surrounds the articulation, being attached around the margins of the articular facets on the tibia and fibula. It is much thicker in front than behind. The anterior ligament, anterior superior ligament. The anterior ligament of the head of the fibula consists of 2 or 3 broad and flat bands, which pass obliquely upward from the front of the head of the fibula to the front of the lateral condyle of the tibia. The posterior ligament, posterior superior ligament. The posterior ligament of the head of the fibula is a single thick and broad band, which passes obliquely upward from the back of the head of the fibula to the back of the lateral condyle of the tibia. It is covered by the tendon of the popliteus. Synovial membrane. A synovial membrane lines the capsule. It is continuous with that of the knee joint in occasional cases when the two joints communicate. Interosseous membrane. Membrana interossea cruris, middle tibio-fibular ligament. An interosseous membrane extends between the interosseous crests of the tibia and fibula, and separates the muscles on the front from those on the back of the leg. It consists of a thin aponeurotic lamina composed of oblique fibres, which for the most part run downward and lateralward. Some few fibres, however, pass in the opposite direction. It is broader above than below. Its upper margin does not quite reach the tibio-fibular joint, but presents a free concave border, above which is a large oval aperture for the passage of the anterior tibial vessels to the front of the leg. In its lower part is an opening for the passage of the anterior peroneal vessels. It is continuous below with the interosseous ligament of the tibio-fibular syndesmosis, and presents numerous perforations for the passage of small vessels. It is in relation in front with the tibialis anterior, extensor digitorum longus, extensor hallucis proprius, peroneus tertius, and the anterior tibial vessels and deep peroneal nerve. Behind with the tibialis posterior and flexor hallucis longus. Tibio-fibular syndesmosis. Syndesmosis tibiofibularis, inferior tibio-fibular articulation. This syndesmosis is formed by the rough convex surface of the medial side of the lower end of the fibula and a rough concave surface on the lateral side of the tibia. Below, to the extent of about 4 millimetres, these surfaces are smooth and covered with cartilage, which is continuous with that of the ankle joint. The ligaments are anterior, posterior, inferior transverse, and interosseous. The anterior ligament, ligamentum malleoli lateralis anterius, Anterior inferior ligament. The anterior ligament of the lateral malleolus is a flat triangular band of fibres, broader below than above, which extends obliquely downward and lateralward between the adjacent margins of the tibia and fibula, on the front aspect of the syndesmosis. It is in relation in front with the peroneus tertius, the aponeurosis of the leg and the integument, behind with the interosseous ligament, and lies in contact with the cartilage covering the talus. The posterior ligament, ligamentum malleoli lateralis posterius, posterior inferior ligament. The posterior ligament of the lateral malleolus, smaller than the preceding, is disposed in a similar manner on the posterior surface of the syndesmosis. The inferior transverse ligament. The inferior transverse ligament lies in front of the posterior ligament, and is a strong, thick band of yellowish fibres which passes transversely across the back of the joint, from the lateral malleolus to the posterior border of the articular surface of the tibia, almost as far as its malleolar process. This ligament projects below the margin of the bones and forms part of the articulating surface for the talus. The interosseous ligament. The interosseous ligament consists of numerous short, strong, fibrous bands, which pass between the contiguous rough surfaces of the tibia and fibula, and constitute the chief bond of union between the bones. It is continuous above with the interosseous membrane. Synovial membrane. The synovial membrane, associated with the small arthrodial part of this joint, is continuous with that of the ankle joint. End of section 19.
Section 20 of Gray's Anatomy Part 2. Talocrural articulation, or ankle joint. The ankle joint is a gigglymus, or hinge joint. The structures entering into its formation are the lower end of the tibia and its malleolus, the malleolus of the fibula, and the transverse ligament, which together form a mortise for the reception of the upper convex surface of the talus and its medial and lateral facets. The bones are connected by the following ligaments: the articular capsule, the anterior talofibular, the deltoid, the posterior talofibular, and the calcaneofibular. The articular capsule, capsula articularis, capsular ligament. The articular capsule surrounds the joints and is attached above to the borders of the articular surfaces of the tibia and malleoli, and below to the talus around its upper articular surface. The anterior part of the capsule, anterior ligament, is a broad, thin, membranous layer attached above to the anterior margin of the lower end of the tibia, below to the talus, in front of its superior articular surface. It is in relation in front with the extensor tendons of the toes, the tendons of the tibialis anterior and peroneus tertius, and the anterior tibial vessels and deep peroneal nerve. The posterior part of the capsule, posterior ligament, is very thin and consists principally of transverse fibers. It is attached above to the margin of articular surface of the tibia, blending with the transverse ligament below to the talus behind its superior articular facet. Laterally it is somewhat thickened and is attached to the hollow on the medial surface of the lateral malleolus. The deltoid ligament, ligamentum deltoideum, internal lateral ligament. The deltoid ligament is a strong, flat, triangular band attached above to the apex and anterior and posterior borders of the medial malleolus. It consists of two sets of fibers, superficial and deep. Of the superficial fibers, the most anterior, tibio-navicular, pass forward to be inserted into the tuberosity of the navicular bone, and immediately behind this they blend with the medial margin of the plantar calcaneonavicular ligament. The middle, calcaneotibial, descend almost perpendicular to be inserted into the hole of the sustentaculum tali of the calcaneus. The posterior fibers, posterior talotibial, pass backward and lateralward. to be attached to the inner side of the talus and to the prominent tubercle in its posterior surface, medial to the groove for the tendon of the flexor hallucis longus. The deep fibers, anterior talotibial, are attached above to the tip of the medial malleolus, and below to the medial surface of the talus. The deltoid ligament is covered by the tendons of the tibialis posterior and flexor digitorum longus. The anterior and posterior taliofibular and calcaneofibular ligaments were formerly described as the three fasciculi of the external lateral ligament of the ankle joint. The anterior talofibular ligament, ligamentum talofibular anterius. The anterior talofibular ligament, the shortest of the three, passes from the anterior margin of the fibular malleolus forward and medially to the talus, in front of its lateral articular facet. The posterior talofibular ligament, ligamentum talofibular posterius. The posterior talofibular ligament, the strongest and most deeply seated, runs almost horizontally from the depression at the medial and back part of the fibular malleolus to a prominent tubercle on the posterior surface of the talus, immediately lateral to the groove for the tendon of the flexor hallucis longus. The calcaneofibular ligament, ligamentum calcaneofibular. The calcaneofibular ligament, the longest of the three, is a narrow rounded cord running from the apex of the fibular malleolus downward and slightly backward to a tubercle on the lateral surface of the calcaneus. It is covered by the tendons of the peroneal longus and brevis. Synovial membrane. The synovial membrane invests the deep surfaces of the ligaments and sends a small process upward between the lower ends of the tibia and fibula. Relations. The tendons, vessels, and nerves in connection with the joint are, in front from the medial side, the tibialis anterior, extensor hallucis proprius, anterior tibial vessels, deep peroneal nerve, extensor digitorum longus, and peroneus tertius. Behind, from the medial side, the tibialis posterior, flexor digitorum longus, posterior tibial vessels, tibial nerve, flexor hallucis longus, and in the groove behind the fibular malleolus, the tendons of the peroneal longus and brevis. The arteries supplying the joint are derived from the malleolar branches of the anterior tibial and the peroneal. The nerves are derived from the deep peroneal and tibial. Movements. When the body is in the erect position, the foot is at a right angle to the leg. The movements of the joint are those of dorsiflexion and extension. Dorsiflexion consists in the approximation of the dorsum of the foot to the front of the leg, while in extension the heel is drawn up and the toes pointed downward. The range of movement varies in different individuals from about 50 degrees to 90 degrees. The transverse axis about which movement takes place is slightly oblique. The malleoli tightly embrace the talus in all positions of the joint, so that any slight degree of side-to-side movement which may exist is simply due to stretching of the ligaments of the talofibular syndesmosis and slight bending of the body of the fibula. The superior articular surface of the talus is broader in front than behind. In dorsiflexion, therefore, greater space is required between the two malleoli. This is obtained by a slight outward rotatory movement of the lower end of the fibula and a stretching of the ligaments of the syndesmosis. This lateral movement is facilitated by a slight gliding of the tibiofibular articulation and possibly also by the bending of the body of the fibula. Of the ligaments, the deltoid is of very great power, so much so that it usually resists a force which fractures the process of the bone to which it is attached. Its middle portion, together with the calcaneofibular ligament, binds the bone of the leg firmly to the foot, and resists displacement in every direction. Its anterior and posterior fibers limit extension and flexion in the foot respectively, and the anterior fibers also limit abduction. The posterior talofibular ligament assists the calcaneofibular in resisting the displacement of the foot backward, and deepens the cavity for the reception of the talus. The anterior talofibular is a security against the displacement of the foot forward, and limits extension of the joint. The movements of inversion and eversion of the foot together with the minute changes in form by which it is applied to the ground or takes hold of an object in climbing, etc., are mainly effected in the tarsal joints, the joint which enjoys the greatest amount of motion being that between the talus and calcaneus behind and the navicular and cuboid in front. That is often called the transverse tarsal joint, and it can, with the subordinate joints of the tarsus, replace the ankle joint in a great measure when the latter has become ankylosed. Extension of the foot upon the tibia and fibula is produced by the gastrocnemius, soleus, plantaris, tibialis posterior, peroneal longus and brevis, flexor digitorum longus, and flexor hallucis longus, dorsiflexion, or the tibialis anterior, peroneus tertius, extensor digitorum longus, and extensor hallucis proprius. Note 74. The student must bear in mind that the extensor digitorum longus and extensor hallucis proprius are extensors of the toes, but flexors of the ankle, and that flexor digitorum longus and flexor hallucis longus are flexors of the toes, but extensors of the ankle. End of section 20.